That was great to get to be able to see that Atlanta data where I spent 9 years at the CDC and really see the focus on the solution. I just came from the reason I couldn't get here earlier is we had our 2-day annual meeting with 500 people from around our programs together for the first time in a long time to really talk about implementation solutions. And I just wanted to just give you just a brief, like 3 minutes, 4 minutes of what we discussed. This is the new UNAIDS data presented as percent increase in absolute number of adult new infections. And you can see which way Kenya is going in this diagram, as well as Uganda. But you can see that there's a whole series of countries that over the last 15 years have had less than a 20% change in adult new infections. At the same time, we've had a 60 to 70% decline in pediatric new infections. So this is a real stark reality for us. So what does this look like, and why is this so? So these are the graphs from Kenya. The orange line is the adult new infections. The red line are the pediatric new infections. So in 2000, before Global Fund and before PEPFAR and before increased resources were available, we had 80,000 new infections in Kenya. But 39,000 of them were pediatric and 41,000 of them were adult. Last year, we had 77,000 new infections, almost the same number, almost identical, well, identical incident rate. An identical incident rate for adults, yet now 71,000 adult new infections. And you have to ask, how could this be with your incident rate the way it is? Well, there's two factors. One of them is and I really want to thank UNAIDS for working with us and with many countries on doing what you just saw from Atlanta, getting really local geographic data. So this is the adult new infections in absolute numbers by provinces. And you can see that all the provinces together don't equal the Kisumu province. And when you looked at coverage of services and absolutely essential testing and treatment services in Kisumu 2 years ago, the coverage of services was less than 30%. The coverage of services in every one of these other provinces was over 65%. And so by not using data in a disaggregated way and looking at just country data, where we're all looking and seeing the countries at 65% or 60%, this is terrific, until you look underneath the data and start looking at site levels and down to lower geographic levels, you begin to see the problems in programming. And it was this very geographic data that really forced us to start talking about the right things in the right places, and really looking at every single place and making sure we were really reaching people. And so over the last 2 years, we've really focused additional resources in Kisumu, which has gone from 33% coverage to almost 60% coverage in the last 24 months. And we believe we can get it to 85% coverage in the next 15 months. But this is a real focus of the program to bring up the high burden, underserved areas up to the low burden, high coverage areas. Now, the other thing that we're confronting, and you might say, okay, well, you didn't explain why the incident rate is flat and you have more adult new infections. And here's our fundamental problem. This is the decade when the epidemic really began to expand in sub-Saharan Africa. This is a box, my weak attempt at area under the curve, because I did this on the plane with this graph, and I really wanted to make it very clear. So in the decade just between 1990 and 2000, we had this many 15 to 24-year-olds in sub-Saharan Africa. 4 years from now, we will have twice that number. 100% increase in the 15 to 24-year-olds. And I just showed you that we haven't changed the incident rate dramatically in Kenya over the last 15 years. Other countries we have, in Kenya we have not. So when you have that ever-expanding population due to the magnificent success of the MDGs, the incredible improvement in under 5 survival. So we had children born free. We had them protected from malaria. We immunized them. We protected them from respiratory and diarrhea diseases. And now they're 15. And there's a 100% increase in the number of 15 to 24-year-olds under 15. And we know that this is the highest slope incident cohort in sub-Saharan Africa. And this is what gives us pause and causes us to worry. So we've come up with this life cycle diagram that's helping us focus our program and our resources that we have. We start over here with this 25-year-old man, and this is data from Slim and Karim that suggests that 25 to 28-year-olds are infecting 17 to 19-year-olds. So if we can find the 25-year-old and get them on ART, we have our first block in the transmission if we can get them virally suppressed. The problem is, as we start looking at age and sex disaggregated data for testing, young men are tested the least of any other cohort. Less than 40% of young men are testing. So this is our first absolute critical challenge that we have to find a solution. So if you walk over here to the 17-year-old young woman, is we have put together a package, a very focused program, multi-sectorial, looking at keeping young girls in school, meeting their needs at the community level, the family level, and in their level, $385 million focused in districts to prevent this child from getting infected as a young adult. So that's our second blockage. And then we know what happens is a 17-year-old who doesn't know she's infected, often this 25-year-old didn't know he was infected, but the 17-year-old doesn't know she's infected, ages up to 20 and infects her 20-year-old partner. And what are we doing about that 20-year-old partner? We're getting circumcision done in all of our sites to expand circumcision, and we invested another $300 million this year in expanding circumcision and condoms to young men. So we're hoping with this three-pronged comprehensive approach of joining protection for young men, protection for young women, and finding the 25 to 30-year-old young men who have not been tested and put on treatment, that we will have a different outcome in the next 12 to 24 months. Because if we don't, even though our incident rates are declining, and since 2000 across all sub-Saharan Africa, it is down by 60%. But I just said that population has gone up by 100%. So the fact that we're flat in new infections in sub-Saharan Africa is actually a sign that some of these programs are working, because they would be going up right now with the incredible uptick in that population. I just wanted to show you, like Atlanta, what is happening in the countries. This is Swaziland. This is where they are right now in the blue bars. This is what they're doing right now and will be completed in September, and this is what they'll do over the next 12 months. We had a large gap in men, helping us by having this gender disaggregated cascades. It's giving us very clear data of the gap between men and women. The exciting thing is, and unbeknownst to me, because I would have had a different conclusion, men link and stay on treatment and are virally suppressed at the same rate as women. The whole issue is access to testing and being tested and then linking. So once a man is found to be positive, he gets to the clinic and he gets on to ART and he's virally suppressed at identically the same rates as women, but women's testing rates are so much higher, 75% versus 55%. So that allows us to concentrate resources, and you can see over the next 15 months, Swaziland will reach 90-90-90 for both men and women. Rwanda has already reached 90-90-90, and will go to 95-95-95 by 15 months from now. The same thing is happening in Zambia, and this is, I just put this up here like you have shown in your slides. HIV is not everywhere in the same way. So this is the number of people living with HIV/AIDS, just done by quartiles, so you can see the darker the red, the more HIV in those areas. They're very specific areas with very high burden of disease. And through our focus and our saturation focus, we're not only being able to saturate in the high burden counties, we're being able to go back to the sustained counties and bring the entire country up to full saturation in the next 15 months. So this is what is possible with working with the Ministries of Health, the Global Fund, WHO, and UNAIDS together in partnership with a community. And so South Africa, Kenya, and Uganda will reach full saturation of 15 to 29-year-old circumcision in the high burden areas, and these countries will reach 90-90, and most of them will reach 90-90-90. But it was in our travels domestically when we began to realize how much South LA and parts of Atlanta and Miami looked like villages in Malawi. So the things that were putting young women at risk, whether it was gender-based violence, poverty, lack of access to education, were putting young men of color at risk in LA, Atlanta, and Miami. And so when we go from hospital to hospital in Swaziland, Tanzania, all through sub-Saharan Africa, we don't see what Carlos is seeing. We don't see Kaposi sarcoma and people presenting with pneumocystis pneumonia again at 26. So we know in the United States we are missing people who are getting infected at 16 and 17, young men of color. We know that this is the same population at risk in sub-Saharan Africa. And we're very interested in that dialogue and being able to share that information back and forth between all of us. So I just wanted to take a moment to really talk about how we are more alike than we are different, and the approaches that you're utilizing around the world and domestically are the approaches that we're translating into action through PEPFAR. It's a privilege to be here because I have so much respect for Julio. He was out there talking about this being possible and convinced Michel Sidibe, and the two of them became the apostles of what we could do together if we focused. And I think when people heard 90-90-90, they didn't think it was possible. Here it is just a few years later after the fast-track document was published, and a whole series of countries and very high-burden countries are going to achieve those goals. This is what's possible when we focus and we work together as a community. So thank you, and I'm so glad to be here at the end.